Assessing, you wanna look at those things, and as I said, you'll have this cottage cheese kind of drainage sometimes too. At least you think that you won't be the one to do that. I have a funny story. So, we had this little patient that was going to dialysis. And I love my dialysis nurses as much as anybody, but let me tell you, they'll tell you, we don't do wounds. We don't do wounds. We don't mess with those wounds. We have nothing to do with it. We want nothing to do with it. So I had this little patient that's going to dialysis, had abscesses all over his body. We were given IV antibiotics to try to clear up the staph that he had going on. Well, he had this large abscess on his hip. And so the dialysis nurse transferred him, and when she did, she hit that abscess, and you talk about, it was down his pants leg, it was all over their seat, it was going all over their floor, and the host smell of rotten eggs, they were all gagging, and the patient was cracking up. He said, yeah, y'all gonna deal with that wound today, ain't ya? But, so, at least you think that you won't, as a therapist, have to see that. You get them in the right position and those abscesses will blow, and there you'll be. So, when you're evaluating odor, like I said, just keep in mind, what it's caused from. And it's a natural part of that. Another thing to consider is your dressings with odor is if you've ever used Duoderm or hydrocolloid, they have a distinctive odor when you remove them. It's not necessarily bad, it's just distinctive. And you can mistake that. So you wanna always clean your wound before you assess that odor, because the dressings that we use a lot of times leave a residual odor that goes along with that wound. Okay, you also wanna assess the pain, the severity, the characteristics of the pain, and any precipitating factors or relieving factors. And this is very important when you're asking someone about in determining the type of wound they have and how severe their the condition can be. So for an example, is one of the things we're going to talk about when we talk about arterial wounds is intermittent claudication, rest pain, or nocturnal pain. So when a patient tells you that they have to sleep in the recliner because their legs hurt so bad if they're out of a dependent position and that they can't sleep at night, that should be a flag to you that the circulation in their legs is bad. You see what I'm saying? They're not getting perfusion and oxygenation. So we ask that. If a patient tells you, hey, this is much better when you put my compression on, it relieves that, then you know that that's a different kind of pain altogether. Does that make sense? So you start to ask them those questions. What can relieve it? What makes it worse? And it gives you an idea about what you're treating. And also how to effectively treat it. So do you all have any questions about wound assessment to this point? No? Okay. So now we're going to talk about pressure ulcers. So would y'all believe me if I told you that a pressure ulcer killed Superman? It did. He had all these pressure ulcers, and that's what finally killed him. So, Christopher Reeves. Yes. So here's the thing. No matter how much money you have, no matter your station in life, none of that matters. If you do not comply with getting pressure off of a pressure ulcer, it is not going to get better. Okay? So that's what I say about the money, and I've seen people say, oh, I'll just do this, or I can buy my way. You can't buy your way out of pressure relief. You have to do the work. And so, you can't just keep going. And the reason I bring this up is because in your lifetimes as therapists, you are going to see many quads and many paras that will choose to do whatever they want to do. And they will pay the price with the tissue on their hiney by not following through with pressure relief. It's a fact. I see them every single day. And you guys have to, as therapists, you guys have to get them in the right chair. You have to get them with the right surfaces. And we have to address that. It's critical. And they have to then be compliant with pressure relief. And so I will say this also, is surfaces help to mitigate some of the pressure. It does not negate the need for turning, repositioning, and removing pressure at frequent intervals. So just because they have a ROHO, that does not mean that I can sit on my hiney all day and play on the computer and never move. Doesn't work that way. Okay, so who's at risk? Patients with decreased mobility, patients with poor positioning, anybody who has contractures, anybody who has incontinence, poor nutrition, dehydration, impaired cognition, or friction issues. So I'll just tell you guys, this is my patient population. I deal with geriatric patients, and it is a rare thing that I see a patient come to us with no risk for pressure ulcers. So keep that in mind when you're dealing with your patients, especially if you deal with the geriatric population, they are at significant risk. So there's 3 factors to consider. So you have to look at the intensity of the pressure, the duration of the pressure, and the tissue tolerance. So what does this mean? If I were to sit you down in chairs, let's just say that your chair has a concrete block that you're gonna sit on top of. And your chair has a gel cushion that you're gonna sit on top of. Which one of you do you think is gonna start squirming first? The concrete block or the gel cushion? That's right, because that's a way more intense pressure and hard surface that you're laying on. So if you can reduce the intensity of the pressure with the gel cushion, then you can improve the time that they tolerate it. So that's what you're trying to do with these cushions, okay? You're reducing the intensity so that you can get more time. It doesn't eliminate the fact that you're gonna start squirming at some point and have to move, but it gives you more time in a comfortable position so that that tissue is not damaged. Does that make sense? So then you look at the tissue tolerance. So if I'm Russell Westbrook, I got great tissue tolerance, right? I mean, I am in tip-top shape, okay? But if I'm Ruth Bader Ginsburg, we got a problem. Does that make sense to you all? Nutrition, age, all of those things play into tissue tolerance. But here's the bad news. If you're a quad, and even if you're 25 and you're a quad, the more time that you are on that and have more pressure and get injury, even if it's just, micro injury where you don't ulcerate, the less tissue tolerance you have every single time. So what I'm telling you is a long history of pressure creates less tissue tolerance and more risk for breakdown. That's why you have patients that'll seem to be doing fine for a while with the surface, and they're like going along and think, okay, we're good, we're good, we're good, and then they fall off a cliff because their tissue tolerance just wasn't there. Does that make sense? Okay, then you also have this issue going along with that is when we talk about friction, is patients, sliding in the bed, and if you think about it, your skin sticks to the bed, right? But your bones and your body slides on down. So you get this shearing effect like this, and it's tearing that tissue. That's why you get those teardrop shapes. So that's another thing that you have to consider when you're looking at your beds and positioning patients. Okay, so when you see this little hiney, and you see these little scattered lesions within it, and it's super shiny like this, that tells me that that patient is shearing, that they're being dragged, they're just shearing away at the skin. Does that make sense? It's almost, and you'll see it sometimes, it'll be rough, like there's tears in the skin. You'll be able to see that. It's pretty superficial, but it has that shiny appearance, and it looks like they're just being drugged. Does that make sense? You'll see this often on heels too, and your patients go and they take those heels and they dig themselves in to push themselves up in the bed, right? Seen that? After a while, that heel will start to blister and get shiny and break down because they're doing that. That's a shear injury. Okay, and so when we talked about this, I should have mentioned this at the beginning. We call these initially started out as the term was bed sores or decubitus ulcers. So we evolved into calling them pressure ulcers because they're ulceration. But now, the new definition, and you're not going to see this in CMS's paperwork until all this has been updated with your hospitals and things, but within the last 2 years, the new definition is now that these are all pressure injuries, okay? So that's what they'll be referred to as, because they are all an injury to your body via these mechanisms that we are talking about: shear, friction, pressure. Okay, so this is that tearing. This is what I was talking about. Can you see how it looks like the skin is almost torn? This is that lady that gets in the chair, and I know y'all seen them. How many of your patients do you see? They can't get up, they can't stand up, they're this. They go. How many times have you all seen that? That is what happened to her, right? So when you're looking at that, keep that in mind that, you know, sometimes I will ask for our therapist to go out, can you please go work on transfer training and see if we can stop some of this shear. Okay, so common signs of pressure ulcers, anywhere you have a bony prominence, usually. So there are times when you can get pressure ulcers that are not on bony prominences. So I just want you all to keep that in mind, that just because it's not a bony prominence, that does not eliminate it as a pressure injury. So let me give you an example. I see very seldom if a person's leg is gone off and touching a bed rail and nobody catches it and it stays there against that bed rail. Even though that's not a bony prominence, it's going to cause a pressure injury. Right? Does that make sense? But usually you're going to see them on the bony prominences. So like vertebrae. You see this is what we call the trifecta. So when you see the pressure ulcer on the coccyx, what position are you in when you're getting pressure to that area? Usually you're laying, right? If you think about laying down, you're not getting them to the ischials when you lay down, right? There's no pressure. So this patient's got it on the coccyx, so that means that that pressure occurs when they lay down. And then when you see the ischial ulcers, that's from sitting, right? So this patient, when they lay and sit, you have to look at both of those surfaces and they're getting pressure with both areas. Does that make sense? So another one, the trifecta. Okay, so we look at pressure mapping, and have any of you seen pressure mapping, or are you familiar with that? Do you know? Okay. So in some of our big metro areas, we have actually therapy groups that do pressure mapping. And what they look at is basically when a patient sits, where is the area that they take the pressure? You know, usually it's on the ulcer, but then you're able to get a custom chair cushion once you map to take care of that. So like you guys have good use of your legs, all of you, so you're sitting in your chairs and your legs make a difference. But what happens to your body when you have paralysis of your legs? How does that change how you sit? So when you have MS, when you have, you know, you're paraplegic, it changes how your body sits, which means it changes the pressure points on your butt, right? So that's why we look at pressure mapping. Also, when you have an amputation, what happens to your legs? What happens to the counterweight? It's gone. So then your leg is more likely to come up and it's moving that pressure point back, right? So you'll see that a lot. Their pressure points change when their anatomy changes or when there's changes in the weight balance of their body. So sometimes, again, we pressure map it. So if you look at this patient, this first one is normal posture. The second one over here, this picture, this is that MS patient. You can see it. I mean, I see on the back of thighs and ischial areas on MS patients all sorts of pressure injuries. Okay. Questions?
How do you do the pressure mapping?
Well, you usually have to have a facility and they have a cushion that they set them on to see it. So, and I have another one in here, I'll show you the foot where we just step them down. But once they sit, there's a cushion under them that has the pressures in it that can ascertain the pressures that they're getting. So you can see that that red indicates the deepest or the highest intensity of the pressure. And see, then what they'll do is then they'll put them on a cushion and they'll measure it again and see that the cushion made the difference. Okay, so, yeah.
Is the foot like designed in such a way that you could stand on it and you wouldn't get a pressure ulcer? I don't understand how that.
It is.
Okay.
It is. So two things. So when you talk about pressure ulcers, you're talking about unrelieved, prolonged pressure. So the foot has foot pads and things like that. If your foot is appropriate, and I've mentioned that because we're going to talk about foot ulcers in a second that you do get, and it does occur because of trauma and pressure, but it's not prolonged pressure like a pressure ulcer. It's because of the way you plant your foot and diabetic changes that occur. So, but yes, generally you won't get a pressure ulcer on your foot. Now, having said that, and when people call me and say, hey, I got a pressure ulcer on the ball of the foot, I'm like, no, you don't. Because it just doesn't happen. With the exception of, if your patient has foot drop, let their foot go to the head of the bed and it lays there, they will get a pressure ulcer. It's just by nature of the design of the way your foot is and that you move it, that you just don't get pressure ulcers typically in that area. However, the heel is a very common area for pressure. Does that make sense?
Yeah.
Just like on your hands, you will no, I'm not saying that you won't, because you will in contracture patients. You'll see pressure ulcers on the hand, but it's just a rare thing that I see that, because most of our patients don't have contractured hands. It's just, you have to look at what's causing it in that patient, but there's more common prominences than others, let's put it that way. Mostly where I come from, I see hips and butts and heels. But it's not common to see even the back of the head for patients to get pressure injuries. Elbows, I see those on occasion. Okay, so we're gonna talk about staging pressure ulcers. And staged pressure ulcers are the only ulcers that are staged in this manner, okay? So any other type of wound, we don't stage it like a pressure ulcer. There is other classification for that. We're talking about pressure ulcers only. And this is according to the National Pressure Ulcer Advisory Panel. They are staged 1 through 4 with a deep tissue injury and an unstageable. And we'll talk about what those mean. And that they're also never reverse staged according to staging. So that means, and I'll explain why that is. That means that once you have a stage 4 pressure ulcer, even when it's healed, it is still a stage 4 pressure ulcer, okay? So if you have a paraplegic and they have a stage 4 pressure ulcer, you get it closed and it opens back up in 6 months. It's still a stage 4 pressure ulcer there that's reopened. The reason is your body only returns at best 80% of the tensile strength into that scar tissue. So that means that you are at high risk for breakdown in that area over and over and over and over and over again. Does that make sense? So we don't reverse stage them. So what we're after with the pressure ulcer is we're after what is the level of tissue injury that happened in your body. So if you think about your layers of tissue, that's what how we're gonna choose to stage them. Okay, so a stage 1 is intact skin. So I'm gonna show you a picture of it. This is what it looks like. It's red. When you push on it, it's non-blanchable. If you remove the pressure from that, it should go away. Okay, you shouldn't have to treat it. It has no dressing, no drainage, nothing is open, intact skin. Y'all with me? So there's another picture. I have a few of these I'll show you. Okay, stage 2. This is partial thickness loss of the dermis, which means it only involves the skin level. There should be no scar tissue left. There should be no necrotic tissue, meaning no slough or eschar in this wound. And it really should not have granular tissue because it involves only the skin. The skin is able to regenerate, so it's going to cover back. So these look mostly, if I can describe it to you, mostly like bluster. Okay, it looks bad, right? That looks bad, but it's really thin. It's only the skin. It's going to come back and it'll heal pretty quickly once you stop the shear and get the pressure off of it. Okay, and these usually occur as a result of incontinence and shearing more so than direct constant pressure. Okay, so here's another one. You can see, and also I will mention that these are pretty painful because it's obviously you're right there at the skin. You can imagine de-ripped blisters. These will also appear as blisters sometimes, and they are clear fluid-filled blisters when they're in stage 2. If you see a blood-filled blister, that is a deep tissue injury, because that's when you see blood, you're indicating that you have deeper tissue damage. So these are all stage 2s. You see they're shallow, there's that, no blood in it, it's a clear filled blister on the heel. Questions about this? Everybody good with the stage 2? You could identify that, right? Okay, a stage 3 is a full thickness wound, which means it goes through the skin. And so you're into the subcutaneous structures, but you're not gonna have fascia, muscle, tendon, any of that visible. So you're into the subcu layers. Now, these can be shallow or they can be deep. So let me give you an example. You all see I have plenty of padding on my butt. There's plenty of subcu there before you get to muscle. They can be quite deep there. However, if you look at the bridge of your nose, you have none. None of us have any, right? There is no sub-Q there. So you go from 2 to 4 like that. On your ankle, you go from 2 to 4 like that. Because once you're through the skin, you're on top of the bone. Does that make sense? So it'll tell you in looking at the stage 3s that you have to look at the structures, the occiput, the malleolus, the ear, bridge of the nose, those places that don't have sub-Q, they're gonna be very shallow and you're just not, you're gonna go from 2 to 4 quickly. Okay, any questions about that? So here's some pictures. Even though this is a shear injury, can you all see that we're through the skin? And you'll see, but you're noticing that you don't have a lot of, on these type of ulcers, you don't have a lot of, you're not having any necrotic tissue. Okay, so stage 4s, these are the ugly ones, because these are the ones that go into the structures. And if you let them get bad enough, you can have loss of function for these patients. So this is an example where we're down to the fascia, right? You all see that tendon in that? And I'll mention that this is from a wheelchair. The patient sits, and that's where that wheelchair hits the back of her leg. And that's what caused that. You see this one? And then again, that looks shallow, right? But it's right on the bone because it's through the skin. So it's a stage 4. This one. Okay, this green this is an old picture, and this is when we had a product called Panafil that gives it that green color. That's not nasty green tissue. I'll just mention that. But can you all see, and also not just when you have muscle, bone, fascia, but also when you have exposed hardware. That's a stage 4 as well. You see that at the top, the hardware. Or your interjoint capsule. This is a knee. See that? And this occurs when the knees are together like this. You know, on a little patient laying. So. Okay.
That's amazing they could get to that place without someone noticing.
Well, here's the thing. So oftentimes you see that and you think in your mind that's neglect, right? You think, oh my God, how could you let it get to this point? How could it get this point? This is not this is not something that just you think of that takes weeks and months to occur. This can be one event that can occur like this. And that one event will result in a loss of tissue. It'll die first because of that ischemic, and then when you debride it, that's what you're left with. One event, so meaning one overnight stay. I had a little patient that her wound was doing great, and I think I have pictures of it. It was doing great. She decided she was gonna stay in she has one of those, what you call a captain's chair. Y'all familiar with that? It lets you recline back. Had no pressure relief in it, and guess what I walked into the next day? And that fast. So even though you see these commercials and people would like to make the assumption, oh, you neglected grandma. It's not always that cut and dry. Grandma can be very debilitated, and before you know it, you're in that mess. So this is that hand tendon. This is from that contracture of the hand. So I have a lot of stage 4s. Also, just for you guys to see, this is that wound, and you think this looked pink, but we actually put a wound back on it, and this is where we got. So it's a big improvement, right? So just to kind of show you guys how some of these do heal. And this right here, when you see that yellow up there, that's not necrotic tissue, that's dried bone. And it will desiccate and get a yellowy color like that. And this is one of those. You all see, these are not bony prominences, right, on this patient. But when you have an obese patient, the rolls themselves that sit on top of the other rolls can cause pressure, right? And so that you can get pressure ulcers that way. Big pannuses can sit and cause pressure ulcers. Okay, then we have unstageable pressure ulcers, and these are ulcers that prevent you from seeing the deepest level of viable tissue because they are covered with necrotic tissue, be that slough or eschar, as we talked about. If you have stable eschar, I already told you guys that's a biological Band-Aid, we maintain that as long as we can. Oops, went the wrong way. Okay. So here's an unstageable. This was from a cast on a patient's leg. They did a cast and it was unstageable, and then you can see at the top, we were able to clean it up and then stage it. Here's another one. Can you all see that's covered with necrotic tissue? Right? Here's one on the ear. And this is the slough. And so, ironically enough, when we debrided this, it debrides all the way out to there. There's slough underneath all the way, so you're just continually pulling it out. And here's another one. So y'all see the common themes. These are all covered with yellow or black tissue, right? See that common theme going along? Come on. All right, suspected deep tissue injury. Now this occurs when you have, usually that single event that I talked about, where you have tissue ischemia and you can have tissue death that occurs. What happens with this is they've over the years, the studies have found that, you know, when you're looking at it and they assess these patients, we didn't know which way they were gonna go. So they would develop, it would have a skin manifestation, we would see these changes that occurred to their skin. They might go ahead and develop a full-blown ulcer, or it might completely resolve itself. And that usually depends on the age and the condition of the patient, of course, you know. But where these were coming from and what happened here. And what they found is, ironically enough, you know, all these nursing homes that got sued, those patients had a hospital stay before, and a lot of these were deep tissue injuries that occurred from not being turned in a hospital, and or a procedure in the OR. And so that has changed a lot of how we have OR practices, is because a lot of these did occur in the OR. You know, imagine it's cold in there, you're on a bypass machine, you know, you're not getting good perfusion, what can happen? So you guys see that's a heel, very common heel. So what happens is either this heel is going to slowly reabsorb that, and it's gonna flake off like an onion skin and be fine, or it's gonna turn black. When you go back and have a necrotic eschar, you'll see these heels change. That's why you tell them immediately start floating that heel, you know, elevate it up, let's get it off, get the pressure off of it. But that's a deep tissue injury. Can y'all see it's a blood-filled blister, not clear-filled? Okay, so here's another one. Now see, it appears as a bruise. So when you look at it, you think, okay, that's a bruise. It'll be a purple, maroon, boggy. You know, if you feel the heels, they're boggy. There'll be changes in the temperature, and it'll look like this bruised area. But it's not a bruise, that's a deep tissue injury, and this occurred in the OR. Now this is one that occurred in the OR, and can you see that it was bruised, and it did look like the other prior, but you see how it started to reabsorb, and it's just that brown color, and it's resolving. And this was a patient that fortunately was a cabbage patient up walking around, and you know, could eat well after surgery, and had the tissue tolerance to actually reabsorb and take care of it without it ever breaking open. But you will have patients, unfortunately, in my line of work, I guess you could say, I see a lot of patients that are not so fortunate because they're really advanced in age. You all see that this, can you see the purple? This is more than a stage 1. You see the purpley color. And so here's another one. See, it's bruised. You see the eschar starting to form there. Here's another blood-filled blister on the heel. And so just to give you an idea, so it goes from this, which you think, okay, well that doesn't look too bad, but you can start to see it break down, and then you'll end up with something like that. If you can see can you all see that purple above it right up here? So when you start to see purple in your peri wound, that's bad, because that usually means that they're trying to break down there too, or pressure, what's going on, so you have to look at that. So patients will always tell me, you know, you ask the question, are you you know, turning, repositioning, are you keeping off of this? And, oh, yeah, I'm doing that. I'm like, no, you're not. You can tell by looking at it, you're not. So, you know, you will be able, you'll get where you can tell because it's changing, it's very limited how it looks. Okay, so I wanted to just kind of give